Good evening. My name's Heather. I am the Regroup Education Lead, and I am delighted to welcome you to the first of the February Seminal 6 webinars. Tonight, we'll be discussing how to manage large hiatal hernias. It's my absolute pleasure to introduce our speaker tonight, Mr. Jihene El-Kafsi, Consultant Upper GI and Bariatric Surgeon in Wexham. Ms. El-Kafsi is the British Benign Upper GI Surgical Society Education Lead, Director for the Karl Storz Hiatal course, and is soon to be hosting the Wessex Full Gut meeting on the 27th of this month. Now, I do believe there's still some tickets left, so do get them before they're gone. August members do get a fantastic discount, so it's worth a look. Now, I've seen the slides for tonight, and I know we're in for a treat. Do put your questions through in the Q&A as we go, and we'll pick them up at the end. Ms. El-Kafsi, over to you.
Thank you very much, Heather. So good evening, everybody. Thanks for joining us for this webinar on managing large hiatal hernias. So we'll start with the definition of what paraesophageal hernias are first, and then what counts as a large hiatal hernia. So there are four types of hernias. Paraesophageal hernias represent 5% of all hiatal hernias. The type 2s to type 4 hernias here are essentially present in older patients. So you've got a different group of patients, population group there, with different comorbidities are presenting with these hernias, rather than type 1s or sliding hernias or patients presenting with reflux symptoms. A large paraesophageal hernia is defined as a hernia that contains more than 30% of the stomach in the chest. The definitions aren't globally agreed on, but this is the most accepted definition. I'll grade out this last bit here that says that 50% of them are thought to be asymptomatic, because I'll show you in a bit it's thought that this is probably untrue. And that's because it's very difficult actually to quantify symptoms from large paraesophageal hernias. So history taking is incredibly important. So it's really important to try and understand patients' symptoms. Systematic review done as part of evaluating a new symptom tool, validated symptom tool for paraesophageal hernias, has found that there are 64 different symptoms out there in the literature that have been attributed to large hiatal hernias. So other than the traditional reflux, both acid and volume, palpitations and breathing problems, patients will get, all sorts of symptoms, mood, bloating, fatigue, dysphagia, cough, and all of these can be attributed to a hernia. I've had a patient who said that she described her symptoms as her chest sounding like an old boiler. So I should probably add that to the list. So how do you get an objective, or as an objective possible, history from your patients? As you know, we use the GERD HRQL commonly for reflux patients. I certainly use it in clinic, and we use it in the National Hiatal Surgery Registry. And I also use the Eckard score for dysphagic symptoms of patients when I see in clinic. So this is a scoping survey from a panel of experts that were looking at coming up with this for the development of the paraesophageal symptom tool, the POSTAL, which is run by the Oxford group with Professor Marker. And a lot of patients use the reflux symptom questionnaire, but that only covers one small part of the symptoms that your patients might be suffering from. So how do you capture other esophageal and extraesophageal symptoms? So these are the 6 questions that the panel of experts have come up with for the POST tool, which is currently undergoing validation through a trial for over a period of 5 years. So the first publication came out a couple of years ago. So we've got a few more years to go before we have this fully validated. But these include obstructive symptoms such as getting solid food down, getting liquids down, chest pain after meals, which could be a sign of partial obstruction of volvulus, shortness of breath after meal, feeling full after eating, and then the heartburn or reflux symptoms. So this is the protocol for the POST study. You can look it up online. It's published, and you can follow that. You can follow it there. So this is a great paper that I will refer to multiple times in this talk tonight, led by a group in Manchester by Ravi Datta, who is one of our colleagues on the Bugs Council, looking at quality of life after giant paraesophageal hernia repair. And you can see here that quality of life improves after, from a reflux point of view, after, in general, after looking at these patients. This is essentially a systematic review of over 4,000 patients, lots of papers published here. So this is a really good piece of evidence that the quality of life does improve after hernia repair from a reflux perspective. I tried to look at cardiac symptoms as well, so other than the traditional symptoms that we've discussed already. But there is some evidence, although modest. There's not a huge amount of literature about this, but there is growing evidence that actually cardiac function does improve, be it from an echo or a CT or MRI, also from even blood tests for BNP levels, etc., after large paraesophageal hernia repair, because you've gotten rid of the compression on the ventricles and the atrium from the hernia. But there's a lot more evidence from a respiratory perspective. This is a meta-analysis of trials for over 200 patients showing a significant improvement in respiratory symptoms and respiratory function after paraesophageal hernia repair for large ones, including a paper by Don Low in there. But this isn't the only studies that are available. There's loads of other studies that have found that actually, even if you take other comorbidities and you take BMI, age, gender, and the Charleston score index out of the equation, respiratory function does improve. So these patients do feel that breathlessness does improve if it was due to the compression from a large hiatal hernia. So it's really important to rule out, first have a full respiratory workup and rule out intrinsic lung disease, and same for the cardiac symptoms. Iron deficiency anemia is present and prevalent in about 50% of patients with where the whole stomach is in the chest. And actually about 5% of patients with iron deficiency anemia have a paraesophageal hernia. It doesn't mean that the hernia is the cause of their symptoms, but if you've ruled out other causes for hernia, it is fairly safe to consider the hernia as the cause of their symptoms. And more importantly, that following paraesophageal hernia repair, these iron deficiency anemias, once other causes have been ruled out, tend to resolve. There's a paper from Don Low here with a number of patients that were followed up prospectively, and another paper here as well, which show the same. And there are plenty of others on this topic. Lots of publications on this topic from the last few decades. So what investigations we'll start with? Obviously, we obviously, following having taken a good history and used our symptom tools, etc. Endoscopy is really important, and I highly encourage surgeons to scope their own patients preoperatively if you're planning on operating on them. You want to look to see if there's a mucosal abnormality in the esophagus, including erosive disease, especially if patients are presenting with reflux type symptoms or dysphagic symptoms. Cameron also here. You can see, obviously, I don't know whether can you see my mouse, Heather? There's a Cameron also here, which is essentially ulceration because of the rubbing of the stomach as it slides up and down through the hiatal because of reduction in blood supply, which has a prognostic significance, which we'll discuss in a bit. And obviously, here's someone doing a J maneuver. You can see the large curable defect and the large hernia there. Imaging is really important. You want to know what else is up in the chest. You don't want to surprise intraoperatively in this patient. Essentially, this is a type 4 hernia with the stomach and other organs in the chest. And barium swallow is helpful to delineate the outline of the esophageal mucosa and the stomach. And it is also a more physiological way to evaluate the hiatal hernia at rest rather than doing it endoscopically. Esophageal physiology has its role in preoperative planning. If you're able to have physiology and then manometry if the manometry probe does go through the LOS, it is helpful. pH studies are helpful in patients with reflux symptoms, however, not so much in patients who are presenting really mainly with obstructive symptoms. And manometry results have to be interpreted carefully because most patients have falsely elevated IRPs, integrated resting relaxation pressure of the lower esophageal sphincter. This is due to a number of factors. One is usually the LOS is squashed by part of the stomach being in the thorax, but there's also falsely elevated IRP calculations due to the fact that essentially the IRP is a calculation that looks at the 4 seconds of the mean relaxation pressure. So the lowest pressure for 4 seconds within a 10-second swallow period of the lower esophageal sphincter. And part of the calculation is based on the selected intragastric pressure. Now, if your stomach is in the chest, then the intragastric pressure is similar to the intrathoracic pressure, and therefore your calculation may not be correct, and the IRP may be higher. So you may get an increase in misdiagnosis of EGJ outflow obstruction for patients. One, because actually that physically the stomach is squashing the lower esophageal sphincter, or two, because the IRP is falsely elevated. But it is helpful to look at the pattern and esophageal clearance. It's also helpful to look at esophageal dysmotility with this. There's plenty of studies that have shown that actually esophageal motility improves post paraesophageal hernia repair, but I wouldn't solely rely on it, especially also that sometimes with the larger hernias, it's difficult to get the probe through the lower esophageal sphincter, so you may not actually have a helpful study. So would you repair or would you watch and wait? So I've looked at the guidelines for this. The EAES rapid guidelines published in 2023. I've got the QR code for you down there, which I've tested again today to see if it's still working, and it is. That essentially recommend surgery over conservative management in patients who are asymptomatic or minimally symptomatic if they are fit enough for surgery. And bear in mind that this takes into account that actually we may not be picking up on the symptoms if you're not taking a thorough enough history, if the patient just is dismissing a lot of their symptoms as not being due to their hernia. This is quite typical. People with large paraesophageal hernias who come to clinic and say, oh, I don't feel anything, I'm fine. You operate on them and say, oh, well, actually, symptoms A to Z, I didn't realize were due to my hernia, have now completely gone and I feel much better. And they also recommend conservative management in patients who are frail. So the key point in this guideline is shared decision-making, conversation with the patient about whether or not to offer them surgery. And bear in mind that the evidence isn't, there isn't very strong evidence for one or the other. SAGES came up with guidelines finally in 2024, published in 2025, which say that there is that they've taken the line that there is not very much evidence to base this recommendation on, whether to operate or not, and also there's limited patient input in the literature to decide whether or not surgery should be undertaken. But essentially, that the crux of their summary of their recommendations based on the fact that few large hernias are truly asymptomatic, and therefore a thorough workup should guide the decision making, and other causes for, say, extraesophageal symptoms such as the respiratory cardiac symptoms have to be completely ruled out, as well as iron deficiency anemia, to find other causes for it. So before you come to the conclusion that you're then contemplating surgery for patients. Here is some of the evidence on which some of the guidelines are based. So Markov model, updated Markov model from Demeister group in the States, which looked at, which is essentially an update from a previous Markov model from over 20 years ago, where they've reviewed the literature from observational studies, which I'll show you in a second, about the risk of developing an acute symptoms or an acute problem from watchful waiting of large asymptomatic hernia. So they put that as 0.017%, but this increases 13-fold if the patients have got Cameron ulcers on endoscopy. So that's why Cameron ulcers are really important to look at and pick up and act on. But they're very optimistic in their elective mortality rates of 0.002% for the less than 65, and actually 0.018% in over 80. And this is why they're saying that actually, if your patient's more than 80 years old, you should go down and watchful waiting probably. But anyone younger than that, then the risk of them having a complication is higher than the risk of mortality. I'm not quite sure. This paper hasn't necessarily change my practice, but these observational studies on which this paper is based for the Markov model as well as the AES guidelines have. So here are a couple of those studies. So looking at natural progression of leaving a large hiatal hernia through a watchful wait approach. There's a Dutch study and a Finnish study. Both show an increase. So the Dutch study looked at the increased probability of developing symptoms or symptoms progressing. It's about 6% a year, with almost a 2% risk of a complication per year, which increases by 17 times if your patient's got a Cameron ulcer, and about by 5 times if they've got symptoms such as chest pain or epigastric pains and obstructive symptoms. And the annual mortality from doing nothing is 0.5%, when actually an elective repair mortality is about 1 in 1,000. And the Finnish observational study over 164 months found that actually patients who present with an emergency have a mortality risk of about 15%. And this varies in the literature if you look at other publications from somewhere anywhere between 5% and 30%. So it is worthwhile, therefore, considering offering surgery in patients who are minimally symptomatic if they are fit enough for it and if they're willing to take the risk. It's really about good consent, and good shared decision making with your patients. So we'll move on to surgical technique. So one of the most common questions that we come across in our practice is whether or not you should be using a mesh or suture. I'm sure everybody knows someone who is a big proponent of one or the other and completely hates the alternative option. So the AES guidelines, again, a very weak recommendation based on weak evidence, suggest a mesh over sutures for closure of the paraesophageal hernia. And the SAGES guidelines decided not to make a recommendation because the evidence for or against isn't really strong enough either way. They looked at 10 randomized controlled trials, and the evidence is there's a lot of contradiction of the evidence, and there's some question about the numbers needed to treat. So I've looked at some of the evidence that's available online. There's a really good paper by the Watson group in Australia with a 5-year now published. This was a few years ago, and I've published their 5-year follow-up of their randomized controlled trial, which compared a lap repair with sutures versus non-absorbable mesh versus absorbable mesh. And the crux of it is that there is no big difference in terms of recurrence rate, but the quality of life seems to be worse with abdominal symptoms in patients with absorbable mesh. Obviously, non-absorbable mesh, there is the added risk of possible mesh erosion and dysphagia, but otherwise, but there isn't any, they didn't come to a conclusion that one is better than the other. There's also there's the group in Chicago that's led by Yelini Vigneswar, and as I'm sure those of you who have come to August a couple of years ago have seen Yelini and listened to her give a talk about their findings for their phase 2 trial for the posterior rectus sheath flap for hiatal augmentation, which at the time showed that after a period of 11 months, they didn't have any serious complications, but obviously it still needs a 5-year follow-up to come through. And this is essentially done robotically, where the posterior rectus sheath is dissected down and left on the falciform for its vascular flap, and then a non-tension repair is done. So it's essentially autologous mesh. And the idea came to her when one of the plastic surgeons came into theatre one day, and she was doing a paraesophageal hernia repair, and said, "Well, why don't you do a flap? You're doing tension repair on the hernia when we're teaching that tension repairs fail invariably, and we do know that there is a very high recurrence rate in paraesophageal hernia repairs." The next question is, should you do a wrap or not? If you've got a patient who's come with dysphagia or obstructed stomach or volvulus, why would you do a wrap? But the SAGES panel recommend doing a wrap because there is evidence that there's a lower recurrence rate and less reflux. And in fact, the number needed to treat is 51 patients. And then the AES guidelines don't tackle that question. And the question is what type of wrap would you do? door or a Nissen or a toupee. There isn't much evidence in the literature. There's not much in the literature at all about specifically about paraesophageal hernia repair, large ones, and what wrap to use. But if you're doing this for a patient with obstructive symptoms and a large hernia, the um, uh, the, the the good points about doing a door is that you're likely to have less dysphagia. You're not doing this for reflux. They don't usually have reflux, these patients. And also you're able to anchor your repair onto the crura. So the risk of an anterior recurrence is lower than with a Nissen. But if you're doing this for reflux, then obviously the Nissen is better in terms of long-term reflux control. And so is the toupee. The downfall is that there's more dysphagia risks, and we know that the patients with large hernias have more esophageal dysmotility problems, and you're not anchoring to the crura. Therefore, there's a theoretical risk that you've got a higher chance of the wrap migrating into the chest. And finally, to PEXI or not to PEXI. So this is a randomized trial that was published in JAMA in 2024, December 2024, with a 1-year follow-up showing that the radiological recurrence rate was lower with an anterior gastropexy than without. But this isn't a symptoms, this isn't a recurrence, symptomatic recurrence, these are radiological recurrence. So again, the jury is out. So, and why would you? So, what about the quality of life outcomes? What's out there that is more, that is essentially, um, that just basically cements that whether you should be operating these patients or not? And again, now go back to the Datas group for Manchester's paper on the systematic review looking over 4,000 patients. They found that even with a recurrence, quality of life post repair is better than not being operated on. They have then looked at mesh and no mesh and found no huge difference. I think there was one paper that showed a significant difference and none of the others did. One paper here, Ilyashenko, showed that actually using patients who've had a mesh had actually better quality of life than the others, but none of the others found this outcome. So not reproducible. And regardless of age, quality of life seemed to be better after large hiatal hernia repair for symptomatic patients. So quality of life improves regardless of the surgical technique that you're using, whether you use a mesh or not, and the age. And that's it. Time for questions.
Fantastic, thank you. I will go to the Q&A. Here we are. So there's a couple of questions that have come through already. If I can encourage everyone to put them through. I have some questions of my own that I'll try and sneak in as well. But first question, have you any experience of using the mesh suture for hiatal closure?
No, I personally don't, and I haven't really looked into that myself. I haven't got much experience from myself in mesh repair. I trained in Oxford with and where we've essentially with Nick Main. I've done a lot of my training with Nick, and who doesn't tend to use meshes. So I'm afraid I don't.
And our next question, in emergency situations where patients present with gastric volvulus, when would you consider doing a repair? Would it be on the same admission or an urgent list? Presumably they've been decompressed.
Yeah. So I wouldn't recommend discharging the patient without if they're fit enough. I wouldn't recommend discharging the patient without repairing them because they can recur. We have had instances where I'm sure we've all come across patients who've been discharged from elsewhere or from your own unit, etc., who come back after a week, 2 weeks, a month, whatever, with a recurrent volvulus and sometimes with infarction. I would recommend temporizing the patient first, decompressing them. Then there is the two options. Some people would immediately, if they're fit enough, put them to sleep, scope them, decompress them, and do a repair. Or you'll have a different group of people who would recommend essentially decompressing them, ensuring nutrition is adequate, and ensuring that any respiratory problems. A lot of these patients aspirate, all that is treated, and then operating on them in the same admission. So personally, I tend to admit them, temporize them, of course, decompress them. And if I can, decompress them endoscopically. And if I can, sometimes you're able to reduce at least partially the hernia with a J maneuver, then I would do that. So, but if I do that because I wouldn't recommend asking your gastroenterologist or your fellow or your gastro fellow or whoever or your nurse endoscopist to do this. You should be scoping these patients yourself, and often they need an anesthetic, and then temporizing them and then operating on them at the same admission.
Would you ever use a double peg for them or no?
You can do again, so the evidence is for pexing, whether it's with a peg or not peg, that's up to you. I think if the patient is fit enough for a formal repair, you should do a formal repair. If you want to pexy them, if you feel that, if you want to follow the evidence about whether if you think that the evidence on pexying the patients is strong enough to go and peg these patients and or pexy them, you should do. You may want to put a peg in for feeding if you think that this patient is going to need additional feeding. Um, I've used personally also, if this is somebody who's not going to be fit enough for a formal hiatal repair, then you may want to reduce the stomach, untwist it, and pexy it, 2-point fixation with a peg or with sutures, to prevent it from involving again. I think you've got to also think about the logistical issues with who would be looking after these patients and their pegs in the community. Because often, if you're not using this for, at least in our ICB in our area, if the peg isn't being used for nutrition, then your nutrition team, the community dietitian nutrition team, will not be looking after this patient's peg for any issues. So if you've got a good community outreach, then by all means, pegs are better than just surgical peg suturing. But if not, you've got to obviously bear that in mind. But it is helpful to use pegs in patients that you're not planning, or pegs in patients you're not planning a formal repair on.
We've had a lot more questions, so I'm going to try and get through them all. There's a query about esophageal physiology studies prior to repair and whether it's of any value where symptoms are clearly attributable to the hernia and whether it would change your management.
So are you talking, it depends on what you're talking about. Are we talking about pH and pH studies and impedance, or are we talking about manometry for dysmotility? So if your patients have got dysmotility, then it is worth trying to have manometry, but I don't think, but again, there isn't any guidelines about this particularly out there to suggest that you absolutely have to or not. But if they've got a giant hernia and you're trying to do manometry, but you can't get the probe down, then you should you still need to think about why you're wanting to operate on this patient and offer them surgery regardless. I think the chances of having a patient with a large paraesophageal hernia and achalasia is quite slim. I think in terms of pH studies, I mean, again, are you doing this for obstructive symptoms? Then I don't really see the point in doing pH studies. But are you doing this just for reflux? Otherwise, the patient has no other symptoms. So are you doing this just to improve their quality of life from reflux? And you could consider doing pH studies. But again, if they've got grade D esophagitis on endoscopy or clear volume reflux history, and this is a huge hernia, then again, you may not necessarily need to.
We've had a lot of questions through. I think you've caused some controversy with your mesh statement. But first of all, what do you do with the sac?
Um, I resect the sac, reduce your risk of having seromas, and it just means that your repair is usually a little bit tidier. Um, that's what I would do.
Does it change your risk of recurrence if there's any sac left?
I think there is some, I've not looked at this particularly for this webinar today, but I think there is some evidence that leaving the sac in may increase the risk of recurrence, but I'm not 100% sure about that. I've always resected the sac because it just helps make the repair a bit more tidy and understand where you are with all the bits and pieces. Yeah.
Sure. Now, this is something we were talking about earlier, but have you got any thoughts on the Colles gastroplasty or the short esophagus?
So yeah, so this is a topic that we're hoping, spoiler alert, to have someone cover at the ASM this year. So, bear that in mind. So, again, so this is a controversial topic, isn't it? Is there really a short esophagus or is this a myth? I think if you're able to um, get enough esophageal length, so you're usually doing these operations for obstructive symptoms. The majority of these patients come with extra esophageal and also obstructive symptoms. So as long as you're able to have enough esophageal length to be able to do a crural repair and a wrap, by doing adequate mobilization, you should be able to achieve, enough length to do a repair, even if it's less than 5 centimeters of intra-abdominal esophagus. But the Colles gastroplasty is a recognized technique for esophageal lengthening. It's in the textbooks are there. So yeah, theoretically, if you need to, you can.
Now, what do you do for weak crura if you don't use the mesh?
Suture and an anterior. I do an anterior wrap for patients with large hernias because that essentially you're buttressing your repair with an anterior with fundus being sutured all around.
And if you've got a wide open space, just to bring it together with sutures.
Yeah, most of the time you should be able to, by doing one suture at a time, you should be able to bring the crura together posteriorly, but also anteriorly, particularly at the 1 o'clock position.
Mm.
And you should, that tends to take the tension off by doing one section at a time. And you're usually in most hernias, you should be able to close it that way. You can use a mesh to cover. You can use a mesh to bridge if you wish. The jury is out. This is what I personally haven't really needed to use a mesh, but clearly the guidelines suggest you can. Clearly the trials, are suggesting that you've got equivalent results with one or the other.
Do you pledget your sutures with?
No, I don't.
There's a query. Do you feel that a mesh repair would be used more if it was a recurrent issue?
Yes, I think so. I think there is, and in fact, if you look at the NHSR reports in the last few years, meshes tend to be used particularly for occurrences.
Um, and how do you gauge the tightness or adequacy of your closure intraoperatively?
So,
No,
yes,
this
it's
is one like one.
yeah. So you can use the old-fashioned eyeballing technique with your opening and closing your Johans and trying to figure out what a food bolus would look like in terms of Johann width, but you can be a bit more precise by using a gastric calibration tube or a bougie like you would in bariatric surgery, and that's what I use. I use a 36 or 38 French gastric calibration tube for my crural closure, and also I leave it in doing the wrap as well. Or if you're lucky enough to have a esophageal planimetry device, so endoflip, then you can use that to measure the lower esophageal sphincter distensibility during the repair or distensibility of the actual repair, not just the LOS of the crura as well. So if there is very little distensibility, you may want to take a stitch out and then remeasure intraoperatively, and then you can see a big difference. So that's very commonly used in the States. It's used in Europe as well. And I think there is an increase in uptake of EndoFlip in the UK, although from the talk, for those of you who did come to the ASM at Woodgis in Glasgow in October, a talk that was given by one of our colleagues in Gloucester, suggested that there is the jury is out in terms of using it intraoperatively, but I think that in the US it's used fairly routinely for that. Even though there aren't specific cutoff points for it that are validated, you can look at the trend.
So there's small queries about intraoperative technique. I'm just gonna Guy Finch has just come back in our queries just to add a comment on short esophagus to say it's very unlikely nowadays, and it used to be existing prior to PPIs due to transmural inflammation, which is perhaps why we don't see so much of it. Just before we come back to, in our last 10 minutes, another question on intraoperative technique. There's a query about, have you got a set follow-up protocol for paraesophageal hernia?
I think the follow-up with these should be, you should see them obviously post-op at 6 weeks, and you should see them again if you can, at 6 months or a year. And I would try and follow them up in a systematic way with objective evidence. So if I've used a quality of life questionnaire pre-op, I would use it again post-op, which is essentially what the NHSR does, and what the new Gorgeous Benign Registry will do once it's launched as well. So the good thing about these registries is that then you don't need to see these patients annually in clinic, because the registry will do it for you for up to 5 years. So you can also then keep an eye on your patient-related outcome measures. Yeah, that's what I would do.
And then I think some of these things we've answered with regards to mesh. I think you've answered that. But what suture do you use intraoperatively?
Well, I use Ethibond, so essentially a braided, non-absorbable suture.
I think that's quite common, isn't it? And do you routinely reset the short gastrics?
Pardon?
Do you routinely reset the short gastrics?
It depends on the type of wrap that that I'm doing, and it depends on whether or not I'm able to, if you're able to achieve a wrap without tension, without twisting, torsion, then you don't need to take the short gastrics. But if you are, so for instance, if you're doing an anterior wrap, you're less likely to need to take the short gastrics than if you're doing a Nissen fundoplication. But again, this is another top. This is a whole other talk of its own, to be honest. And the jury's still out, and there's still people who are all for taking short gastrics all the time, and others that don't, and some who depend on how tight their repair is. Personally, if I'm doing a 360 wrap, then I find it really difficult to be able to achieve a wrap without torque, without taking a short gastrics. But if I'm doing an anterior wrap, invariably for a door, so if I'm doing a repair for someone with a large hiatal hernia with obstructive symptoms, then I generally don't tend to take them.
Excellent. I think that is all of our questions. So just going to give it a second just to make sure that there's no further questions from our audience. But in the interim, can I please remind you all about the full gut meeting on the 27th? Registration is still open. It will be fantastic. And to tell you that next week's webinar, same time, Wednesday, 7 o'clock, will be on advances in interventional oncology in liver surgery. So please do register. I'm sure it'll be excellent. Unless there's any further questions, is there anything you'd like to add, Ms. El-Kafsi?
No, that's it for me. I think, Heather, unless you've got any more questions or any other comments you want to add, I'd like to thank everyone for joining us tonight.
I think maybe just one last question from me, as the RU education lead, if I could ask, what do you think should be the training pathway for trainees learning this operation? Because it's a different beast to your simple anti-reflux.
Gosh, it's really difficult to answer that question off the bat, to be honest. I think that, yeah, certainly you need volumes, and if you're not achieving you're not achieving your volume in these procedures, then you should consider doing a fellowship in a high volume unit, where you're able to do large hiatal hernias. I mean, it is a different beast, as you said, Heather, from two points. One is patient selection, and the diagnostic pathway is very different. And the reason why you're doing this operation is very different. But certainly, I think that if you're not able to get the numbers in your training, or if you haven't done a resectional job where you're comfortable in doing, extensive esophageal mobilization in the mediastinum, which you would be if you do a high volume resectional job in your training, then certainly a fellowship is would be helpful.
Excellent. There are no further questions, so I think we can draw it to a close. Thank you very much to you and to our audience, and look forward to seeing you all again, hopefully at the full gut meeting, but if not at the ASM, where we're going to dig into hiatal hernias in a bit more detail.
Thank you very much.